Okay, good morning. This is Mark Arnold, Senior Vice President of Marketing with Zap Surgical. Welcome and thank you for joining us today for our 8th webinar of the Winter SRS webinar series. Held every Thursday between now and May 13. This new series does include 12 talks over 12 weeks. So if you haven't already, I do encourage everyone to visit the srswebinars.com website to review not only the upcoming presentations, but also register to view recordings of prior webinars as well. And one final item of business before we get started. If you'd like to submit typewritten questions at any time during today's talk, you can do so by using the Q&A button found in the Zoom console. Time permitting, your questions will be addressed at the end of today's presentation. So without further delay, I'd like to introduce today's moderator, Dr. John Adler. Dr. Adler is the CEO and co-founder of Zap Surgical, inventor of the CyberKnife system, and professor emeritus of neurosurgery and radiation oncology at Stanford University. Dr. Adler.
Thank you, Mark, and thank you everyone for joining us this morning. I'm, as always, delighted to present today's speaker because he's a dear friend as well as kind of one of the leading lights in both radiosurgery and especially in and around the treatment of meningioma. I think very few people have thought as deeply and interestingly about what meningiomas are, how we should treat them, what they represent, and really, I think you're going to enjoy today's session very, very much. And so Mike spent much of his life, the vast majority of it at UCSF, where he ran the brain tumor program there, and also radiosurgery, was the head of radiosurgery. More recently, I don't know if it's a step up or a step away, but he's now the big dog at Miami Neuroscience Institute, where he continues a lot of his work in tumor and radiosurgery and continues his interest in meningioma. So I'm delighted to have Mike here this morning. And Mike, take it away and show us why you never need to operate on cavernous sinus meningiomas anymore.
Okay. All right, thank you, John. And Mark, good morning, afternoon, evening to everybody. I hope this is enlightening for you because after reviewing a lot of this literature, I didn't think that I was really that much further ahead, I'm sorry to say. But here are my disclosures, none of them relevant to this presentation. I usually like to give a structured presentation no matter what the topic, so I'm going to go through the process that I went through for this review in preparation for the presentation, give a little bit of a clinical background on cavernous sinus meningiomas, show a case example, and then talk about treatment results, both for observation, radiation therapy, radiosurgery, and microsurgery, and I'll review some recent papers. So in preparation for this presentation, I conducted with one of the FIU students 4 different Pubmed searches between the years 2000 and 2020, human subjects only, English language only. And you can see that we crossed cavernous sinus meningioma and observation and radiosurgery and radiotherapy and surgery. And the resulting reports included a total of 868 different references. There was a lot of overlap between these different searches, and there were a lot of the results that weren't relevant to cavernous sinus meningiomas at all. So I went through the references and pulled out, you can see 15 of the 88 for observation, 57 for radiosurgery, 59 for radiotherapy, and 66 for surgery. There's not a chance in the world today that I can review all this information. Also, I'll be giving you the summary results of some of this. But cavernous sinus meningiomas are relatively uncommon as far as intracranial tumors go. They turn out to be a surprising number of incidental meningiomas. And I think there's a problem with the definition. And part of this problem for both cavernous sinus and what are so-called, quote, paracellular meningiomas has been the impetus for myself, Steve McGill, and Javier Fernandez at UCSF to plan a meningioma nomenclature article in order to help with some of these definitions. So the problem when you look at these papers is that a lot of these papers, particularly the surgical ones, are not talking about meningiomas confined to the cavernous sinus proper. They usually refer to those extending into the cavernous sinus or extending out of the cavernous sinus, involving other compartments, either in the middle cranial fossa, the orbit, the sphenoid sinus, the sella, or the suprasellar region. So the problem right from the get-go is the definition as to what we're talking about. Are these all cavernous sinus meningiomas confined to the cavernous sinus proper? And I'll say that for the radiosurgery papers, probably most of them are primarily confined to the cavernous sinus and not exophytic. The other problem that with cavernous sinus meningiomas, we know from previous publications back in the late 90s, early 2000s, that postmortem pathologic specimens show that it's very common to see invasion of the adventitia, the internal carotid artery, and the epineurium of the nerves that travel both within and in the lateral wall of the cavernous sinus. So the theory being that if you really want an oncologic resection, you have to do an en bloc removal of the cavernous sinus contents to get a complete microsurgical removal, and we know that's not possible. It's not surprising that the patients who present with these tumors have headaches, fifth nerve, double vision, 3, 4, 6, ptosis 3, facial numbness 5, pain 5, and reduced visual acuity when they extend up through the roof of the cavernous sinus and compress the optic nerve or optic chiasm. The natural history of meningiomas in general, unfortunately, even in 2021, not well defined. For cavernous sinus meningiomas, I can only find one paper that dealt specifically with the natural history of cavernous sinus meningiomas, and I'll review that. But back when I was at UCSF, one of my residents at the time, Mike Shagru, was very prolific, very industrious, reviewing a lot of the published literature on meningiomas. And he looked into data on 675 patients with untreated meningiomas published in the literature, looked at the growth rate. Most of the tumors, as you can see here, were very slowly growing. Rarely did they grow in an exponential fashion. But it's interesting that the tumor that was most often one to show growth if it was above 2.5 centimeters in diameter was cavernous sinus meningioma. There are papers in the literature, which I won't review today, which talk about the molecular pathology of cavernous sinus meningiomas as compared to other locations as published by the Yale group. But unfortunately, I won't be able to go into that today. But it's surprising that cavernous sinus meningiomas as a group are some of the most common to progress radiographically when they're above 2.5 centimeters. Now, when Mike looked at the factors affecting outcome for the treatment of cavernous sinus meningiomas, he looked at over 2,000 cavernous meningiomas, divided them into 3 groups. Those that had, quote, gross total resection, we know that's not possible. All of these, even when they're gross total by the pathologic anatomy, have to be at least Simpson 2, subtotal resections, and then another group, group 3, which was radiosurgery. And he looked at the recurrence rates and found a significant difference for those treated with surgery alone, either near total resection versus subtotal versus radiosurgery. You can see the recurrence rate was significantly lower for those treated with radiosurgery, and that the cranial neuropathy rate in late follow-up was significantly lower as compared to surgery. So decision-making regarding patients recommending and balancing the risks of treatment versus the tumor left untreated have to be taken into consideration, patient factors and tumor factors. Before I sat down here, I just saw a 91-year-old with a parasagittal meningioma with surrounding vasogenic edema in the supplementary motor area, who's got left leg weakness and has a coincident diagnosis of AML in remission on treatment. So obviously we're not going to do anything, and the patient factor in his case will be the biggest determinant in deciding what to do next. So here is the only paper that I could find that specifically spoke about the cavernous sinus meningiomas. And I guess in Europe, the tumors, whether they're acoustics or meningiomas, behave in a more benign fashion. But there were 53 patients, predominant females. Most of the patients had either minor or major symptoms, and major symptoms were primarily related to cranial neuropathy and double vision. But the important thing about this paper was the great median follow-up of 10.8 years for a single institution. The take-home message, if you look at progression-free survival, is at 5, 10, 20 years, these tumors grow really slowly. So there's no rush to do anything for these patients, and particularly if they're asymptomatic, the patient can be simply observed either for documented growth or development of neurologic symptoms that are specific to the tumor site. None of these patients that come in asymptomatically need treatment in the next 2 weeks, not a chance. And if you told the patients that, you'd be not informing them correctly. So this group found that first thing that they did, because there was a large number of females and because there's information showing that PR positivity is about 60% in meningiomas, and we know that in gender reassignment treatment, male patients who are undergoing reassignment get put on high-dose progestins it seems to be an increased incidence of developing meningiomas. So the first maneuver is stop any kind of hormone supplementation therapy, treat the pain syndrome with pain modulators like gabapentin. In the short term, if the patient has the acute onset of double vision, you can use steroid medications for a few weeks. And then symptomatically, you can help control them by using prism glasses for their double vision. If the conservative measures fail, then they recommend radiotherapy as a primary first line of treatment, whether that be radiosurgery or radiofractionated stereotactic radiotherapy is up to the treating radiation oncologist and neurosurgeon, I would hope. And these are tumors that are truly confined to the cavernous sinus, not exophytic into other compartments. But when the patients fail and there's new symptoms related to extracavernous extensions, such as compression of the optic nerve or chiasm, then surgery can be done for decompression without an attempt at gross total removal. Now, Bill Caldwell, very well-known skull-based surgeon, I think Bill is very honest, reported on outcomes of this so-called decompressive surgery for cavernous sinus meningiomas. None of the attempts to go through the operative triangles described by Parkinson to try and remove these tumors completely, understanding the documentation of the pathologic anatomy, involvement of the adventitia, epineurium, et cetera. But 50 patients, 70% had cranial nerve deficit pre-op. 25 out of the 50 had surgery plus some form of radiotherapy afterwards. And you can see that the cranial neuropathy presentations are as listed there for cranial nerves 2 to 6. Half the patients had headache. And because Bill has a special interest in meningiomas of that region that involve the orbit with proptosis, hence the large percentage of patients with proptosis. So a cavernous sinus meningioma, pure intracavernous meningioma, would not cause proptosis. How could it? And the example that Bill included in his paper here, you can see this is a 5-compartment meningioma. It involves the sella, the cavernous sinus, the suprasellar region, the middle cranial fossa, and the infratemporal fossa. And here's the result of the decompressive operation. Tumor volume is obviously smaller. The portion exophytic to the lateral wall has been removed. There's a little encephalomalacia. The subtemporal component of the tumor remains. So this is not a radiosurgery target by volume. This is a fractionated, fully fractionated stereotactic radiotherapy treatment plan. But overall, the patients did well. Tumor control rates were good. If you looked at just the patients who had surgery alone, they had an inferior result, but not significantly compared to the patients who had surgery plus radiotherapy treatment. And here's the thing that we're always concerned about, and that is new cranial nerve deficits after this kind of decompressive surgery, even in the hands of an expert skull-based surgeon. 40% had new cranial nerve deficits post-op and, quote, most recovered. And as I showed you in the Kaplan Meier's, the 5-year progression-free survival appeared to be similar in both groups. Here's the overall complication rate, and this is the kind of thing I reported for other meningioma locations, because it's not just cranial neuropathy, but you've got wound infection, CSF leak, 2%. So Not everybody gets every complication, but the most common deficit or problem after this decompressive surgery is cranial nerve 3 deficit, which is a major functional disability for the patients. So there was one other surgical paper I thought I'd review, and that's by Anil Nanda when he was down at Shreveport. And it's interesting that in discussing microsurgical results, resectability outcomes, and tumor control, the first table in their paper was patterns of recurrence in contemporary radiosurgery series. And what they showed is that the failure rate's low, it's not zero, and most of the patients recur in the first 5 years after radiosurgical treatment. The contemporary microsurgical series, you can see that some of the follow-ups are short, some of the follow-ups are very good, but these are usually, the longer follow-ups are patients who may have had combined treatment. And you can see that the recurrence rates tumor control rates are not perfect, and recurrence rates in general appear to be higher after microsurgery alone, similar to the reports by Caldwell. And this is the result of the Nanda group. The green line is microsurgery, some form of decompressive operation plus radiosurgery versus microsurgery alone. So the combined treatment clearly superior. Again, cranial nerve deficits, you can see them listed here. Cranial nerve 3 was most involved pre-op, and then new deficits, cranial nerve 3 was the most common nerve to be affected. About 70% of these get better in follow-up. Well, in this case, 90% get better in follow-up after surgery. Now, one of the problems I mentioned at the beginning is the definition of what is a cavernous sinus meningioma. Is it truly just confined to the region of the cavernous sinus, or does it extend in other compartments? So this is the chart from Anil's paper, and you can see that these tumors are all over the place. There's one primary cavernous sinus, one, yet the paper is about the results of cavernous sinus meningioma surgery. It's not. It's about operating on the exophytic component, or that component that's causing optic nerve or chiasm compression. So this is a really decompressive operation and surgical series. It's not primarily those that are confined to the cavernous sinus. So taking from a chapter from the Handbook of Neurology on Meningiomas, which Bill, one of his fellows, did for me, culling the literature and looking at it up until about 2019. In general, the results for surgery are as follows. Whatever the surgeons want to call gross total, 20 to 82%. We understand it's very difficult to operate in here without causing problems, and I'm glad to see that the surgical philosophy has transitioned over time. And I've been around long enough, like John, to know that back in the late 80s and early 90s, there was a lot of surgical mayhem for patients, unfortunately. And the morbidity rates are not insignificant. Mortality rates are not insignificant. And, the tumors are slowly growing. So if you follow them long enough, the percentage that will recur will be higher as time goes on. And the same holds true for any form of treatment. The predominant pattern of recurrence is early if the patients are operated on. So what about different forms of radiotherapy? We know there's radiosurgery 1 to 5 session treatment. 5 to 25 treatment is fully fractionated stereotactic radiotherapy. And I took this paper from a review conducted by the Lausanne group and Marc Levivier, looking at the literature. 2,800 patients, looked at 2 different platforms for delivery of radiosurgery and then fully fractionated radiotherapy. You can see the median marginal doses. These are biologically equivalent, so there's no difference there, with mean follow-ups that are pretty good. I mean, we're out 5 years, which is good. The range is longer, obviously. There's, from somewhere around 2 years to out to greater than 10 years, but these are the mean follow-up numbers. And the progression-free survival, as you'd predict, not significantly different no matter the modality of radiotherapy that's used. So in general, for radiosurgery and fractionated stereotactic radiotherapy, an effective treatment, well tolerated. As you'd expect, the tumor volumes are smaller for the radiosurgery series than the fully fractionated. And the anti-tumor, anti-vascular effect is higher when you deliver a large dose of radiation in a short period of time. So radiosurgery would be predicted to produce a tumor volume reduction that was greater than if you did fractionated treatment, and that turned out to be significantly true in this review. Tumor recurrence was low, between 3 and 5.8%, not significantly different. A lot of the deficits that the patients came with pre-op recovered. So I usually tell the patients there's about a 35 to 50% likelihood of improvement in cranial neuropathy with primary radiosurgery or radiotherapy. And new neurologic deficits are rare. Adverse radiation events are also acceptably low. So let's review a couple of recent specific papers. This is a paper from Australia, 112 patients. You can see there's a mixture of cavernous sinus meningiomas and pituitary adenomas, but they separated out the results by diagnostic group. A good period of follow-up, median follow-up over 6 years. And you can see for cavernous sinus meningiomas, excellent 5 and 10-year tumor control. Only 32% of the tumors were smaller, 65% were the same when they used the hypofractionated 5-session treatment. Here's the Kaplan Meier result for freedom from progression. You can see it's very good. It's better than the surgery alone Kaplan Meier that I showed you from the Nanda group. These are cranial nerves affected pre-treatment and outcome after treatment, improved a small number of patients for the entire group, about 20% or better. Late radiation toxicity in this hypofractionated group. For the meningioma group, the likelihood of stroke, pituitary insufficiency, or cranial neuropathy, 1.7, 1.7, and 10.5. Still acceptable when you think about the decompressive cranial neuropathy rate of 40% that occurs immediately after surgery. So for fractionated treatments, the control rates are very good. The follow-up's longer than the microsurgical series. The tumor volumes tend to be larger when you're fractionating versus when you use single session treatment. And the tumor control rates appear to be very good. The likelihood of hypopituitarism is actually lower than the 6 to 8% I put here, given the Australia paper, but something to be on the lookout for. So every year the patient should have assessment of the hypothalamic pituitary axis, and the etiology of this failure is unclear, whether it's actually the failure of the gland itself or in the region of the hypothalamus related to releasing factors that are impaired. All right, let's focus on radiosurgery. This is the Pittsburgh group. You can see here long-term follow-up in 200 patients, 5 to 18 years after radiosurgery. In 60% of the patients, the radiosurgery was used as the primary form of treatment, and I'll get back to that in a minute as compared to when it was used as an adjuvant treatment method after prior microsurgery. And 17% of the patients had recurrence, meaning they had subtotal resection or some form of near total resection, but had imaging evidence of recurrence and were treated with radiosurgery after that. Tumor volumes were actually a little bit on the larger side. I was a little bit surprised. The median marginal dose was 13 gray, and in this location, limited by proximity to the optic apparatus, where we know that the maximum point dose is probably somewhere between, depending on visual status, between 800 and 1,000 centigrade in a single session. The Mayo group and Bruce Pollack published that up to 1,200 centigrade for very small volumes can be tolerated without side effect. Freedom from progression long-term, pretty good, 75%. If you follow meningioma patients out to 20 to 25 years, both the Mayo Clinic and in Europe, some of the papers published by Teet Matheson, by Michael Link, the recurrence rates are up in the 50% range. So you have to follow these patients long-term. This was the figure that was presented in that paper as opposed to from Pittsburgh. Overall control rate outlines control rates for primary radiosurgery, adjuvant, and salvage treatment. and improvement in pre-existing cranial nerve deficits and 26% decline in function in 12.5, and similar to the Australia paper, adverse events acceptably low. These are the Kaplan Meiers. I think if a patient has salvage treatment, it's not a manifestation of failure of the radiotherapy, it's a manifestation of the biology of the tumor that recurred in spite of prior surgical treatment. And as you'd expect, the larger the tumor volume, the greater the likelihood of a permanent neurologic deficit, which just makes sense. The clinical outcomes of the radiosurgery are listed here: deficits before prior surgery and deficits after prior surgery, a significant difference. So if the patients had prior microsurgery, they're more likely to present and start off with cranial nerve deficit before the treatment. This is a summary of cranial nerve function after radiosurgery, and you can see that there's some optic nerve toxicity, but in general, the new deficits are thankfully rare, and trigeminal nerve appears to be affected the most. So there was a paper here that was put together by the International Stereotactic Radiosurgery Society guideline for treatment of cavernous sinus meningioma, a systematic review, articles published between 1963 and December 2014. This paper was published in 2018, and there were a number of abstracts, just like I showed you in my review, where there was only 49 which were selected for inclusion in the analysis. And the paper showed that the tumor control rates were quite good. Neurologic preservation of function was very good. Resection should be considered for tumors greater than 3 centimeters in diameter, or if they're exophytic. And symptomatic cavernous sinus meningioma patients, if they have compressive neuropathy or problems, should be considered for this decompressive surgery. And adjuvant or salvage radiosurgery for residual recurrent tumors can be utilized. But the literature is limited to level 3 or class 3 information. There's no prospective randomized trial of observation versus radiosurgery, microsurgery versus radiosurgery, and there won't be. So it's up to the treating clinician to make the decisions in this regard. I mentioned earlier about the influence of prior surgery. I just showed you the difference in the Pittsburgh paper of the incidence of cranial neuropathy if the patients had had primary treatment with radiosurgery versus adjuvant treatment after microsurgery. And this is Mike Shagru did the same thing and looked at new deficits, prior microsurgery, 60%, radiosurgery alone, 25%. I showed you that. And another review by the Pittsburgh group showed that the cranial nerve function was more likely to improve in cavernous sinus meningioma patients that had a cranial nerve deficit if radiosurgery is used alone as compared to if it was combined after prior microsurgical treatment. So Bruce Pollock and the Mayo Group looked at the radiosurgery complications from cavernous sinus meningiomas, and you can see the complication rate tends to rise because radiation is the gift that keeps on giving. And recently they published an interesting paper on the risk of internal carotid artery stenosis or occlusion after single fraction radiosurgery, not specifically for benign paracellular, or not specifically for cavernous sinus meningiomas, but obviously it's relevant. And the likelihood of internal carotid artery stenosis or occlusion was not insignificant. At 10 years, it's 12.4, but thankfully the symptomatic stroke rate is very low, only at 1.2%. But the authors commented that when we're considering treating patients with cavernous sinus tumor locations, that we should discuss this potential problem as a long-term risk. Now, I talked before about the difficulty with defining what cavernous sinus meningiomas. I showed you the Nanda group. Only one of their surgical tumors was specifically or was wholly confined to the cavernous sinus. The rest of them were exophytic and extended into other compartments. And I think that was the indication for considering the surgical approach. Now, when you're talking about radiosurgery, you know, it's a little bit different than microsurgery. Let's face it, it's a little bit of a video game. You sit down at the console, outline what you think the tumor volume is. You or the physicist or the radiation oncologist or as a combined group come up with a preliminary treatment plan, look at the conformality, look at the dose to surrounding structures that might be at risk. And Ian Paddock has been a big proponent of this in at least in the United Kingdom, looking at different radiosurgery centers and done quality control studies. But this was an interesting paper by a number of practitioners from both from Greece and Sweden, looking at treating physician contouring practices for organs at risk. And unfortunately, when you're trying to define what is the optic nerve, what is the optic chiasm, the results showed that there was a large variability in practitioners trying to contour organs at risk for the same clinical case. Luckily, the highest consistency for outlining organ at risk was for the right optic nerve in the case of a cavernous sinus meningioma, but still not as good as you would think it would be. So this inability of the index finger on the hand of the physician who's got the mouse outlining the organ at risk is much more variable than one would expect. Not only that, but when it comes to targets, whether it be a brain metastasis or a cavernous sinus meningioma, the consistency between outlining what is accepted as the true target volume and what is actually done is very low. So for cavernous sinus meningiomas, there's the lowest correlation, and the variability in contouring was much higher than the authors expected. And so further work is needed to standardize contouring practice. So you can see if you have an exophytic cavernous sinus meningioma that extends into orbital, cellar, supracellar, Meckel's cave compartments, there can be a lot of variability in what you're defining as tumor. The dural tail, whether that represents tumor versus hypervascular tissue, is still up for grabs. Most of us don't treat that extensive tail, others do. So a lot of variability. But overall, the results for radiosurgery are very good, excellent 5-10 year progression or tumor control rates. Once we get out to 15-20 years, the results decline as expected. Recurrences are low. Most of them occur, if they're going to occur, in the first 5 years. And about 35% of the patients can have improvement in deficits. And luckily, the likelihood of a delayed deficit is rare. So here's a recent case from a couple of weeks ago, 46-year-old man, recent onset double vision, physical examination. He has paresthesia on the right, V1 distribution of the trigeminal nerve. He has a mild right sixth nerve palsy. He's an engineer working full-time. He has 2 teenage daughters. He needs to keep working. His MR scan shows a cavernous sinus meningioma. Okay, so based on all the information I just showed you, because he's symptomatic, the tumor is more than 2.5 centimeters. It's bright on the T2 weighted imaging. When we presented the options of observation, microsurgery, or radiosurgery, I recommended primary radiosurgery. I knew I couldn't get this tumor out. I knew that if I tried to get it out because it wasn't exophytic, that I would cause more harm than good. And this is an example of the treatment plan with the, in this case, what turned out to be the Gamma Knife platform. You can see the what we think is the tumor volume outlined in the conformity of the prescription isodose line to the tumor margins and protected organs at risk, in this case, the right optic nerve and the optic chiasm. And that treatment was done in 5 sessions, not a single session, 95 shots. Each treatment session took 77.9 minutes. The patient was able to stay still enough with the mask to be able to tolerate the treatment. But of course, if the patients need to take a break after 45 minutes, it's not going to affect the end result biologically of that treatment. So conclusions, unfortunately, most of the data guiding treatment recommendations for meningiomas in general, and particularly cavernous sinus meningiomas, is class 3 at best. And that's what the international working group also determined. Thankfully, there's a trend away from open surgery for truly cavernous sinus meningiomas. That is, those confined to the medial, lateral, inferior, and superior walls of the cavernous sinus as we understand it. And most surgical series are, as in the Nanda series, they're really talking about exophytic tumors, tumors that involve the primary cavernous sinus but extend out of it. And it's those extensions large in a way that may be causing some of the compressive neuropathy. Unfortunately, definitions are not standard, both within surgical series, like what tumor are you talking about that you're operating on? And I showed you the patient from Bill Caldwell. That was a 5 fossa tumor. Radiosurgery target volumes, there's a lot of inconsistency in outlining what we think the tumor volume is and also the organs at risk. Now, microsurgery is more risky, but can provide more immediate decompression for the optic nerve and chiasm if the patient has visual loss, that's for sure. And radiosurgery, we understand, is less risky. As far as I'm aware, I didn't see any publications of treatment-related mortality as compared to the microsurgery group where there was some. And there's a greater tumor volume reduction with radiosurgery as compared to fractionated treatment. But no matter the modality of radiotherapy, the long-term freedom from tumor progression appears to be good. This is a working flow chart that I took from Dr. Caldwell's paper, which talks about the management. I agree with this flow chart. If the patient is symptomatic and the tumor is small, you can use primary radiotherapy or radiosurgery. If the patient has unexpected cranial neuropathy, you could do a biopsy, either transcranial or transsphenoidal. If the tumor is large and there's an extra cavernous component, then you can use primary radiotherapy, maximal decompressive surgery. We don't recommend cavernous sinus. I don't recommend it. I've done it a few times. The results weren't good. And if the patient is asymptomatic, I think it's safe to follow the patient. We just showed you the natural history results from Calmaderas and his group, and the tumors are very slowly growing. And if the tumors are extra cavernous, and by the fact that if they're over 2.5 centimeters, the Chagru paper showed us there's a very high likelihood, 87% likelihood that the tumors will grow in the future. So you have the option of still observing the patient, and if there's documented further growth or new symptoms, treating them with radiotherapy and reserving surgery only for biopsy, or if the clinical condition is somehow unusual. So that's all I have to say. Sadly, we're not very much further along than we were 15 years ago because we don't have any class 1 information, but thankfully we've backed off on the aggressive surgical approaches.
Brilliant, Mike, good. This is a complex topic, and have more than a few questions for you. Invite you to take one at a time. First, a good friend of yours asked a question I was going to ask as well. Talk a little bit about the dosing for these tumors, and especially how to think about hypofractionation.
Right. So I think what our Li-Jean Ma asked that question. I worked with Li-Jean for 28 years back at UCSF. And I think if the tumor is more than 2.5 centimeters, or you're worried about the single fraction dose to the optic nerve or optic apparatus, then you fractionate. And if the tumor's less than or equal to 2.5 centimeters, I think we would use 5-session treatment. And don't ask me why we use 5 instead of 3. I don't know if there's any difference. I didn't see any papers comparing the two modalities. But if it's smaller, under 2.5 centimeters, and the dose to the nerve and chiasm can be below the threshold of 800 to 1,000 centigrade, then I think you do single-session treatment. If the tumor is greater than 3.5 centimeters, and if there's an exophytic component, I think the best results, and Steve Chang from Stanford reviewed this a few years ago, comparing fractionated treatment to single session treatment, and the larger tumors do better with greater fractionation, which is as expected.
But how about the dose? Do we have a clear dose
No,
or for a small, so single fraction? Do
No.
we know the definitive best dose?
no. Well, as I showed you in the Pittsburgh series, the dose range from 10 to 20 gray. Most of us in an extra cavernous location would consider 15 gray at the margin is sufficient, because there seems to be some data, class 3 again, that as you increase the dose above 15, you don't necessarily improve tumor control, but you increase the adverse radiation event risk profile. In the cavernous sinus, the constraint is primarily related to the optic nerve and optic chiasm. And I think most of us would do what Mark Linsky had previously called inflection planning, meaning you might have a lower dose at the anterior superior part of the tumor within the cavernous sinus, and at the mid portion of the cavernous sinus and posterior portion might have a slightly higher dose depending on your delivery system. But I think most of us are using somewhere, 14, 15 gray standard if we can.
Well, that seems to almost be a dogma at this point, and I just question, and I'm not saying that it's the wrong dose. It just seems to me it still can be volume and anatomy dependent. But I'll leave that for another time.
Yeah.
So somebody asked about proton therapy. Talk about, does proton therapy decrease long-term risk and organ at risk?
Yeah. Now, I'm not a radiation oncologist, so I'm putting that out there, but been around radiotherapy for a while. And one of the great thing about protons, of course, is the Bragg peak or spread out Bragg peak, no exit dose. But the problem is with the delivery systems, the number of beam paths that you need or that you can generate from a practical point of view to deliver the dose are way more limited than 192 beam paths, for example, in a gamma knife treatment or a CyberKnife treatment, for example. So theoretically, I think that is possible, but in practice, it's not. And I work at a facility where we have a proton unit, multiple linear accelerators, MR Linac, CyberKnife, tomotherapy, gamma knife. And we don't use protons for these tumors. We use photons, and we use either a delivery system currently that we deliver 1 to 5 sessions. And if the tumor is too big, we use photons. We don't deliver the radiation therapy with protons. And the rare occasion where there's a recurrence after primary surgery, adjuvant radiotherapy, and the tumor comes back again and it's not surgical, then sometimes we'll do that as a last resort if there's no medical clinical trial available to the patient. I didn't really look at proton therapy per se for this particular topic, and we don't do radiosurgery with protons.
I personally totally agree with you. So another question, any tips for optimizing contouring inside the cavernous sinus? Obviously subtle shades of enhancement and what's tumor, what's not, the issue. Any suggestions?
Yeah, the only thing I would suggest is 2 things. Number one, when you use the T1 weighted MR imaging for treatment planning, make sure that it is fat suppressed. Number 2, make sure they don't use a phase contrast sequence. And by that, I mean, when they use phase contrast, then the internal carotid artery shows up as a white object. So you can't separate it, particularly in the suprasellar region, from the associated tumor. And if you're not using fat suppression, you can't sort out tumor from fat in the clinoid or fat in the posterior aspect of the orbit. So fat suppressed, non-phase contrast. I don't really like the T1 cube post-GAD, even though it suppresses the arterial flow. You just have to work with your radiologist to come up with the appropriate imaging protocols. But fat suppressed, no phase contrast. Those would be my tips. And I think the important thing is to look if there's an exophytic component, particularly into the sella, then you need to look at the You can get help from the T2 weighted images, from the T1 coronal pre-GAD versus post-GAD, things like that that'll help you.
They're not easy. I've been there. I'm going to make a statement and you can react to it.
Sure.
Is there any reason that somebody doing skull-based surgery today and really all meningiomas, but especially cavernous meningiomas, shouldn't have to be also duly qualified in doing radiosurgery? And I think it's almost malpractice to not be duly trained so that you make the right technical judgments both in the operating room and eventually doing radiosurgery. Your thoughts?
Yeah, I don't think it should be a requirement, because in practice currently, a lot of people do. And we're lucky that in many centers, we now have tumor boards or skull-based conferences where it's multidisciplinary. So we have the input of our colleagues in radiation oncology and medical oncology. So we're not operating on an island here. So I think to try and mandate that neurosurgeons should have a fellowship, for example, in radiosurgery, I think is going to be hard to prove. But I agree with you entirely. If you're going to be a tumor doctor, tumor neurosurgeon, you should know lots about radiotherapy and radiosurgery. I've had a fellowship here for 2 years, and I've had 0 domestic applicants from neurosurgeons, none.
And I think that I'm going to argue that's because people think you can hand off these cases, and I think that there's some complex set of decisions that need to be made in the operating room that are intimately involved in doing the treatment planning and following these patients. And if you force the two together, you'll have better decision making for patients.
Right. So I think, the surgical approach for, quote, separation surgery, I'm not sure how much I want to believe in that as being really that important, because if you give fully fractionated treatment, you can be safe with normal tissue organs at risk. So I'm not sure whether doing an operation to put a piece of fat between the optic nerve and the cavernous sinus meningioma is worth it, but I don't know. But I think that, neurosurgeons have the most input and are most helpful in assisting with the target definition because of their knowledge of the anatomy, skull base, and elsewhere. And obviously, we don't know as much about radiation biology as radiation oncologists, so the decision making about single versus multi-session treatment, depending on size and dose to structures at risk adjacently, obviously that's the input of the radiation oncologist. So I think it's very important that we work as a team, split it 50-50. We did that at UCSF, we do it here. I think that's the way it should be.
So Mark Levivier did ask a question about the separation surgery to some extent. He's referred to it as a chiasmopexy and actually trying to get separation between the chiasm and tumor. And have you done that?
No.
Do you know of people doing it?
Yeah, it's published, separation surgery. I don't know that I'm the biggest, anytime, Mark's asking about chiasmopexy. So, dissecting the arachnoid and trying to separate the optic nerve, do a clinoidectomy, open the optic canal. You don't have to do a clinoidectomy to open the optic canal, but in order to open the optic canal safely, I think you do need to do a clinoidectomy, if that makes sense. So, did I say that right? No, in order to open the optic canal, you don't need to do a clinoidectomy. That's correct. So you can unroof you can take off the roof of the optic canal without doing a clinoidectomy. And don't forget, there's about a 3 to 10% incidence in somebody who already has compressive optic neuropathy of making them worse. That means anywhere from slightly worse to blind just by drilling the optic canal. I've seen that happen. So, and then you've got all the other things that, go along with an open operation in that location. It's very difficult, whether you're doing it transcranial or endoscopically now with some of the centers that have expertise in there. I don't think that when you've got a fractionated method of treatment delivery that has equal results to radiosurgery, I don't think separation surgery is necessary.
Quite pointedly, how many optic nerves have you and your team injured in the last, let's say in the modern era of radiosurgery, the last 15 years or so?
As far as I'm aware, none.
Yeah, so that's kind of feeding into my little, kind of lecture. I think in carefully done optic nerve injury is very, very unusual. And I've been someone who's over the year pushed very, very hard and treated to doses much in excess of what the dogma would teach us, sometimes with fractionation, sometimes without. And I think that one can go much higher in dose than people realize, as long as you're treating partial volumes of the optic chiasm or optic nerve.
Yeah, it was interesting. When I was reviewing this, I came across a paper by an ophthalmologist talking about the ocular movement and visual outcomes following treatment of cavernous sinus meningiomas. And not surprisingly, they look way worse than what the neurosurgeons present.
Much worse. They're terrible. I mean, anyone who's ever operated in orbit knows just how hard it is to do good work. So that's why radiosurgery is so good.
Yeah, I mean, when I was at UCSF, I mean, we were a steady supply, not terrible, but a regular supply of ocular difficulties to the neuro-ophthalmologists. Anyway, anything from a frontalis palsy, levator injury, fourth nerve, third nerve.
Well, third nerves are god awful. So
okay. Yeah, terrible. It's tough, really tough.
One last question: is there any room for screening after a long-term follow-up in patients for carotid occlusion?
No. So, I mean, for large tumors need surgery anyway. Combined approach, yes. So
I'm talking about people post radiosurgery and carotid occlusion stenosis is a complication.
No. So I saw one patient in my time at UCSF who already had carotid narrowing on the side of her cavernous sinus meningioma. She had primary radiosurgery. It was more than, I think it was about 12 years post. She came back and her carotid was occluded. I mean, imaging wise, she had no clinical symptoms, but she had a small right temporal lobe infarct. So I'm sure she had a watershed injury, was completely asymptomatic for it. I don't put the patients on, I usually put, if the patients have no carotid narrowing, I don't put them on aspirin. If they do, I put them on 81 milligrams a day based on what? I don't know. I feel like maybe they're protected from an occlusion event with low flow, but no science for that. And I just follow them with regular imaging. I don't do MRAs or anything like that. If I see the carotid narrowing, I usually just put them on aspirin and tell them that the artery is getting smaller. But the risk of a symptomatic stroke, thankfully, is 1/10 of what the incidence of imaging occlusion of the carotid is. And Mark Levivier asked for large treated needs surgery anyway. Yes, I would always, and I think Bill Caldwell's gone this way too, that if you have to operate on a patient because of neurologic symptoms or signs and difficulties, that I would not, especially if the patients are young, I would be more inclined to use the radiosurgery or radiotherapy as in an adjuvant setting rather than waiting for the tumor to recur.
Gotcha. Okay, Mike. Hey, great talk as always. I learned a lot, and I'm sure our audience did as well. And thank you. Okay, I look forward to seeing you soon in South Florida. Thank you, everyone, for joining us today. And go out, have a good day, save the world.
Thank you.
Need us. Okay.
Bye.
Thank you. Bye-bye.